We are thrilled and honored to host our next guest, Professor Richard Lane. And before I will read his very impressive bio, it's a good opportunity to congratulate him for the another very distinguished award that he received just recently by the American Psychosomatic Society in recognition as a Distinguished Scientist Award. Um, and to present Professor Lane, Richard D. Lane, MD, PhD, is Professor of Psychiatry, Psychology, and Neuroscience at the University of Arizona, a clinical psychiatrist and psychodynamic psychotherapist with a PhD in experimental psychology, systems neuroscience, and emotion research. And he was one of the first researchers to perform functional neuroimaging studies of emotion in the 90s and continues studies on emotion, emotional awareness, and neurovisceral integration to the present using functional MRI. His research on emotion, the brain, and heart disease has been funded by a variety of sources, including K and several R01 grants from NIH. He's the author of over 200 papers and book chapters and is senior editor of 2 books which have collectively been cited over 40,000 times by Google Scholar. As an educator, he served as director of the psychotherapy curriculum for psychiatric residents at the University of Arizona for over 2 decades and has received 7 awards for teaching and mentoring. He was president of the American Psychosomatic Society in 2005 to 6, elected member of the American College of Neuropsychopharmacology, distinguished life fellow of the American Psychiatric Association, and elected honorary fellow of the American College of Psychoanalysts. Yes, and just last week he received the 2024 Distinguished Scientist Award from the American Psychosomatic Society. Guiding themes in his research and scholarship have been the importance of integrating systems neuroscience with psychological conceptualizations and the need to bridge basic science and clinical application. These themes have driven his work on emotional awareness and alexithymia, the role of emotion in mind-body interactions, including susceptibility to sudden cardiac death, and the mechanisms by which memory and emotion interact to make enduring change in psychotherapy possible. The latter work was the basis of a Fulbright Fellowship in Vienna last year, hosted by the Sigmund Freud Museum. His talk today is titled The Challenge of Enhancing Emotional Awareness in Patients with Bodily Distress. So thank you, Richard.
Well, thank you very much, Ori and Edith, for inviting me. Can you all see me and hear me well? I'm having
yes, perfect.
Good. I'm having a little trouble on my side here in terms of seeing you at the same time that I'm trying to share my slides. So let me try again here. Well, hopefully, okay, it'll advance. Good. All right. Well, it's hard to believe that 5 years have passed since I last presented in Tel Aviv to this society. Clearly, a lot has happened. First COVID, and now the latest war. I just want to take a moment to say that my heart goes out to all of you for what you're going through at this time. The events of October 7th were horrific. I appreciate that the entire country was traumatized and that achieving a sense of safety in the current climate is difficult, if not impossible, to imagine. So you have my deepest sympathy and support. In this talk, I'll highlight early life adversity, but clearly trauma at any age is relevant to the problem of somatization and brings up the question of what we can do about it. The role of insight in the change process is something that I've thought a lot about. And I think I can be most useful to everyone here by presenting what I truly believe. And that is that I think a multitude of corrective emotional experiences in the context of the therapeutic relationship is more important for change than insight. This talk, the invitation to give this talk was stimulating to me, and it provided an opportunity to bring together 4 different elements of my work that I haven't all brought them together before. I spoke about 2 of them 5 years ago, but emotional awareness is an organizing framework across all 4. And so these 4 elements that will constitute this talk involve emotional awareness and affective agnosia, which Edith and Yaakov referred to. The second is the role of early childhood adversity and why it confers risk for chronic pain. And I'll argue that it has to do with compromised emotional awareness as a result of early life trauma and neglect. The third area, which was the focus of the Fulbright Fellowship in Vienna, which is the model of enduring change in psychotherapy involving the reconsolidation of emotional memories and requires an expansion of emotional awareness. And then, last but not least, a new element, which I've only presented at one other conference, and involves a paper that we're in the process of writing, involving combining bodily interventions with psychotherapy to promote emotional awareness. This is very much consistent with Edith's talk, and it's just kind of an extension, I would say, of what she presented. So I think to focus our discussion here, that'd be useful to start off with a case. And it was a case of a woman who I saw when I was running a consultation liaison psychiatry service. The story, as you'll hear it, will sound quite familiar to you. And it was a one-time consultation. I don't have follow-up information. We invited her for outpatient follow-up, but she wasn't interested. But this is the kind of the basis of what I want to talk about today. So this is a 41-year-old unmarried woman who was hospitalized for workup of abdominal pain. Abdominal ultrasound and endoscopy were negative. And so the medical team asked for a psychiatric consultation. And the patient said that she had had persistent abdominal pain for the past 3 months. And so we took a history and found out that, we asked her if anything had happened 3 months ago that was related to the pain, and she said no. And we took a history and found out that 3 months, prior to this admission, her mother had died. And we said to her, we asked you if anything had happened that was related to your pain, and you didn't mention this. And she said, well, I don't think it's related to my pain. Okay, so clearly we might say absence of insight. Okay, so this is actually her adoptive mother who took her in at the age of 8. Her biological parents were alcohol dependent and were physically abusive. And she was placed in a series of foster homes, one after another, until she was adopted at age 8. And then finally, she connected with this woman who adopted her, who was very kind and nurturing. The mother suffered from diabetes and peripheral vascular disease. And during the last 5 years of the mother's life, the patient cared for her on a daily basis. They were very close. 1 week before her death, after a medical setback, the patient contemplated the possibility of her mother's death and was overwhelmed with a feeling of grief. A week later, mother died of a GI vascular obstruction. And since her mother's death, the patient has experienced no feelings of grief or sadness of any kind, but she has abdominal pain. And in addition to pain, she suffered from anhedonia, had neurovegetative symptoms of depression, and met criteria for major depressive disorder. So this is just such a stark example of someone who clearly was grief-stricken, had grief a week before, but has no grief or sadness now. So what happened to the grief, and why does she have pain? The case is also important because we think that early adversity, you know, parents being alcoholic, abusive, one foster home after another, contributed in some way. And I would say it contributed to a compromised distress tolerance, as well as perhaps compromised emotional awareness. Now, when I was in Vienna, I taught a course on the change process in psychotherapy, and I taught 12 lectures. And I was fortunate to have an outstanding academic host, Stefan Düring, who is the chair of the Department of Psychoanalysis at the Medical University of Vienna. And he attended every lecture. And in general, we kind of agreed about how the change process works. But when he heard this case, I said, this was an introduction to the idea of reduced emotional awareness, an inability to experience grief. And he said, and an example of a deficit, right? And he said, this is not a deficit, this is defense. And so this led me to give a lot of thought to the question, you know, how can we reconcile these defense and deficit accounts? And what I concluded was that primitive defenses like somatization, splitting, projective identification, and dissociation all involve an impairment in mentalization. Okay? So like I think of somatization as unmentalized emotional distress or impaired emotional awareness. And, you know, for the longest time, of course, people trained psychodynamically always understandably think in terms of defense, right? But I think a way of reconciling these two and integrating them is to think about emotional awareness as the symbiotic inverse of defense. In other words, we want to perhaps overcome defense with insight. And the idea is that it's kind of an all or none phenomenon. But I think that from an emotional awareness standpoint, emotion starts in the body, and then we talk about 5 levels of transformation of that information that's associated with a full range of emotional experiences. I'll also say that I think insight on the part of the therapist is essential, but as I'll argue, not really necessary in the patient. Okay, so issues raised by this case in the outline of this presentation: impairments in emotional awareness often lead to a focus on somatic symptoms. Early adversity is a risk for lower emotional awareness, which predisposes to chronic pain and somatic symptoms. Enduring change in psychotherapy occurs by updating schematic memories with new emotional experiences. And yet, I think when it comes to somatization, psychosomatic patients, we need to do more. And so I'll argue that within this model that I'll present, that there's a rationale for combining bodily interventions with psychotherapy to promote emotional awareness in this context. Okay, so there's this paper by Francis Creed and his colleagues in the UK from 20 years ago now. This is actually the basis for the change in DSM-5 to somatic symptom disorder, where they stopped talking about medically unexplained symptoms for reasons such as I'll now demonstrate to you. So they looked at about 150 patients in an outpatient medical clinic, and they divided them into those who had organic explanations. In other words, they had objective symptoms that, objective findings that explained the symptoms. But then equal number of patients who had medically unexplained symptoms. And then they looked to see the extent to which symptoms varied as a function of 2 variables. First one was negative affect, anxiety, and depression, right? And the other was early childhood adversity. So what you see in blue, in both cases, is a number of symptoms when you have neither. What you see in red is when you have both. Yellow is when you have early adversity, and the purple is when you have depression and anxiety. And if you look at the mean levels, if you will, of the two categories, they aren't that different. What really seems to matter is negative affect. But also, it's negative affect plus early adversity. And the question is, well, how does that fit in? And I would say that with early adversity, that's capturing unmentalized distress, okay? So how do we know that somatic symptoms are due to emotion? Well, Omar Vandenberg in Leuven, Belgium, and his group have done really, I think pretty remarkable work to demonstrate this. So they had LSR refers to patients who have a low number of somatic symptoms, and HSR is high symptom reporting. So the HSR people who have a lot of those somatic symptoms. And what they did was they presented international affective picture system pictures to people and had them view the pictures and then rate somatic symptoms afterwards, as well as their negative emotion. And so what you see in the lighter colored gray, across the x-axis, there are different categories of emotional pictures. So high arousal negative, disgusting, and high arousal negative that are threatening. And then the third one is low arousal negative affect, then high arousal positive affect, low arousal positive affect, and even neutral. In all cases, there's statistically significant more somatic symptoms that are rated after seeing pictures. Okay, high symptom reporters are looking at pictures that evoke negative emotion, and they have more somatic symptoms. They have carried this further in I think, remarkable neuroimaging study that was just published last year. Okay, and what this imaging study showed was that there's activation of pain centers in the brain, what they call the neurologic pain signature, and somatosensory areas, but not affective centers of the brain. So this was 33 patients with functional somatic syndromes, 30 control subjects. They viewed pictures in blocks and they rated how much negative affect and how many somatic symptoms they had. This is really showing that the brain is processing affective stimuli differently, okay? And interestingly, it's not, negative affect is not activated. Okay. So how do we explain this? The levels of emotional awareness framework, which we first published our first paper in 1987, I think explains the observations that I just shared with you. Although the Vandenberg group has not yet integrated emotional awareness into it, but I'll be talking to them about it. And it gave a beautiful introduction. Okay, so key thing is that we said that emotional awareness is a cognitive skill like any other. And this is an ability that it develops over time. And similar to Piaget's stages of cognitive development, developmental transformations occur in the capacity to be aware of one's own feelings. According to Piaget, cognition becomes more differentiated and integrated with development. And we said in this paper that the higher the level of emotional awareness, the greater the differentiation, integration, and desomatization of emotional experience and expression. So it's not that emotion starts in the body and goes from more concrete to abstract and conceptualized and leading to differentiated experience. There's still a bodily component, but the bodily component is progressively less as you go up the hierarchy. And following Piaget's stages of cognitive development, we talk about 5 levels of emotional awareness. What you see in yellow corresponds to Piaget's sensory motor stage of cognition. We said level 1 is bodily sensations, level 2 is action tendencies. So visceromotor and somatomotor responses. Only at level 3, you have discrete emotional experience, feeling happy, feeling sad, feeling grief. At level 4, you have blends of experience, the ability to feel happy and sad at the same time. And then level 5 is the ability to appreciate that kind of complexity or blend in yourself as well as in another person. I'll point out this nested hierarchy here on the right. And so we call it levels because emotions are changing all the time. And when we measure levels of emotional awareness with our scale, we're looking at the trait or typical level that a person operates at, but it also lends itself to a state interpretation, because basically at any given moment, as you go up each level, it modulates the levels that came before. And that's a construction of experience. And I would say that in the patient that I described before, that she was at level 3, overwhelming feeling of grief the week before her mother died. But then after the mother died, her level of emotional awareness got reduced, okay, to the somatic level. And I'll try to explain why that is. I should tell you that the levels of emotional awareness framework has been successful. We have 255 papers published so far. And I'm going to tell you about one in this slide. Also, thanks to Joe Szymanski in Haifa, we're in the process of creating a Hebrew electronic version of levels of emotional scale. We have electronic version. The scale itself has been translated into 20 languages. This is the standard paper and pencil format. We ask people how you'd feel in different situations, how the other person would feel, and people write as much or as little as they need to answer those 2 questions. But it's time consuming to hand administer and hand score. So we have digital versions. The English version came out in 2010. We had a German version come out last year in 2023. And now we have 4 more in the works, including Hebrew and Arabic. Okay. So here's an imaging study involving post-traumatic stress disorder. And what I'm showing you here, paper published in 2008 in Psychosomatic Medicine, was the findings associated with the control group. Okay, so basically the people with PTSD and the controls had traumatic stress. And what they had people do was read a script to promote recall of the trauma. They also read scripts that would enable recall of neutral experiences. And so this was done in the scanner, and you could subtract the activity in the brain due to the neutral context from the trauma context to get brain activity specific to trauma. And then we correlated that with levels of emotional awareness scale score. And so we found a positive correlation here in the medial prefrontal cortex and rostral anterior cingulate cortex. This is part of the default network. It's where conceptualization happens. It is connecting to it's overlapping with the paracingulate gyrus, which is kind of the mentalizing area. So this is basically bringing emotion to a higher conceptual level. And what's interesting is that the patients with PTSD did not have this pattern. And one might say that the fact that these were control subjects, they didn't have PTSD because they were able to mentalize, because they were able to contextualize the emotional distress associated with the trauma. So one of the early imaging studies that we did, we collected heart rate, we collected ECG and measured heart rate variability, and we showed that there was a positive correlation between activity in the medial prefrontal cortex and greater vagal tone, okay? So that initial study was extended by a meta-analysis done by Julian Thayer and Tor Wager, included our study and 11 others, and definitely showed this positive correlation. So what does that mean? When you're calm and relaxed, right, and vagal tone or heart rate variability is high, you're able to engage the medial prefrontal cortex and reflect and mentalize. And at the same time, you're having top-down modulation that is dampening arousal and leading to actually greater differentiation of experience. Conversely, that same positive correlation means that when you're highly aroused and vagal tone is low, your medial prefrontal cortex essentially goes offline. And that's what we had in mind when we published this paper and this neurological model of what we called affective agnosia. So I wasn't totally thrilled with the term alexithymia. I've been fascinated with alexithymia for over 40 years. But it literally means lacking words for emotion. And we know from the neurological literature that that could mean an anomia, where you know what something is, but you don't have the word for it. But I think that, based on patients with severe deficits, it's more of an agnosia. They don't have any idea, what it is that they're experiencing. And I think Jakob gave an example of a patient, maybe the second one, who asked him how he felt. He has no idea. Okay. So we think that the way somatization happens, and this is very consistent with Jakob's circular model, you have activation in the body, you're emotionally aroused, maybe due to a social context. Patient doesn't know that. And the bodily arousal isn't explained. It's not experienced as an emotion. It's not experienced as a feeling. And the person doesn't know what to make of it. They think something's wrong. It raises anxiety. It increases arousal further, and it goes around and around as a short circuit. And naturally, one would think, well, let's just bring it to the higher level. I think that's where the idea of insight comes from. Okay. But I think it's, as we heard, it's complex and it's not so simple. Okay. Now, I was very fortunate to have an extraordinary graduate student and postdoc work with me named Ryan Smith, who's now principal investigator at a brain research institute in Tulsa, Oklahoma. And he actually co-authored the paper on affective agnosia with me. I told him about a case of someone who came to me because she said that she did not feel feelings, and indeed she didn't, which was kind of remarkable. It's a lecture in and of itself. But we brought her into the laboratory and showed her IAPS pictures, and she did not have skin conductance responses, okay? But we also showed her Ekman faces, and she was able to accurately identify facial expression. So she could recognize emotions, but that interoceptive process was compromised. But also, importantly, the affective response wasn't generated in the first place. So Ryan said, there are actually 3 processes involved. We've been highlighting the conceptualization issue. And of course, that's very, very relevant. But there are actually three processes involved. Someone might have impaired emotional awareness because they're not generating an emotional response in the first place, okay? Then they might not be aware because maybe they're generating the response, but they don't mentally represent it. They don't put it into words. They don't symbolize it. But he also pointed out that, you know, someone could have the first two processes intact, but basically not care about emotion or not pay attention to emotion. So you need conscious access. And this is, you know, consistent with the idea that we have a global workspace of consciousness, and you need access to that, right? So it requires all three. And as a matter of fact, he went to London and worked with Carl Friston and Thomas Paine, and they actually did a computational simulation and showed that there are 8 different pathways to low emotional awareness involving these three processes. Okay, so I'm going to skip this because this is just a summary of the three-process model. But again, you have a situation, you have affective response generation, active, then an affective response representation, and then you need access to the global workspace. And this is where defenses and cognitive control can play a role as well. Okay. So now I am moving to the second part of the talk. This is a paper we published in 2018, Bias Competition Favoring Physical over Emotional Pain, Possible Explanation for the Link Between Early Adversity and Chronic Pain. I was mentioning to Edith that the American Psychosomatic Society has officially changed its name, and the journal Psychosomatic Medicine is changing its name as well. It's going to be the Society for Biopsychosocial Science and Medicine. And that's what the journal is going to be called, Biopsychosocial Science and Medicine. And of course, George Engel was the person who coined the term biopsychosocial in his seminal article in Science in 1977, an alternative to the biomedical model. He was an internist, obviously psychodynamically oriented, and he wrote a paper on the pain-prone patient. He said, pain is a psychological experiential phenomena requiring participation of higher nervous centers. Pain may occur without sensory input. And here's the key idea. Pain often seems to serve as a kind of psychic regulator. So think about, you know, my patient who I told you about at the beginning. When a strong aggressive drive is not fulfilled, pain may be experienced instead. When guilt is present, pain seems to serve as a kind of atonement. I think Ori had a comment in the chat about that. And then when a relationship is threatened or lost, pain serves as a replacement. So that would be kind of patient I presented. Here's the key idea. In certain pain-prone patients, pain seems to substitute for the experience of other more painful emotions. So Engel didn't talk about early adversity, but I think that early adversity fits very well here. In childhood, emotions are interpersonally regulated. In the context of abuse and neglect, this type of regulation does not occur or is limited when it's needed most. A common solution is to tune out internal emotional distress and become vigilant for external threats. Abused children also do not receive the empathic attunement and mirroring from others that would enable them to know what they're feeling. This impairment in mental representation is associated with impaired medial prefrontal cortex activation and impaired top-down modulation of subcortical generators of affect. And so I think what often happens in adulthood is that there's a predisposition for somatization, but maybe it doesn't become manifest until there's some kind of maybe benign injury, some source of pain. And then people discover that the kind of unmentalized distress and bodily distress that they have during everyday social circumstances it's actually relieved somewhat by focusing on the pain. And it's kind of analogous to, it's an involuntary process, analogous to the intentional infliction of self-injury, for example, in borderline personality disorder, when emotional distress is overwhelming, self-injury reduces emotional distress. So it's kind of analogous to that. So how might early adversity amplify pain? Well, impaired mental representation of emotion is linked to decreased mentalization ability, decreased capacity to identify stressors, impaired capacity for attachment. Unmodulated subcortically generated implicit affect is associated with decreased vagal tone for the reasons that I explained. And the vagus is anti-inflammatory. So if you have decreased vagus, you have heightened inflammation, and inflammation promotes allodynia, that is, benign stimuli become painful. And so attention plays a very important role in promoting physical pain experience in the context of emotional distress. In the context of early adversity, unpleasant bodily sensations may be interpreted either as emotional distress or physical pain. If physical pain is selected and attended to, that will amplify the experience of physical pain and decrease the experience of emotional distress. The decrease in distress will be experienced as rewarding, which will be reinforcing this cognitive bias. Okay, as such, pain can serve as a psychic regulator. And this is a diagram that I won't go through now from that paper that basically points out how early adversity is associated with compromised emotion concept, poor emotion concept acquisition, low prior expectations for emotion, impaired emotion regulation ability, which leads to more chronic negative affect, which heightens inflammation. And so when you then focus on the pain, that's combined with the inflammatory increase in pain. And as a result, you see low emotional awareness and high self-reported pain. All right, part 3. So how does change happen in psychotherapy, and why do I talk about corrective experiences as opposed to insight? So we published this paper in 2015 on memory reconsolidation, emotional arousal, and the process of change in psychotherapy. My co-authors included Lynn Nadell, who has been at the he's now an emeritus professor who's at the forefront of this changing concept of memories as malleable, not fixed. That was proven in rodent studies in the year 2000. Sigmund Freud, by the way, was the first person to describe it in 1896. It took a century to prove it scientifically. Lee Ryan, head of our psychology department, did important imaging work showing that episodic and semantic memories are more highly interrelated than we thought before. And Les Greenberg created emotion-focused psychotherapy, and in this paper really pointed out how emotion is so central to the change process. When I saw you last in 2018, we were preparing this book, which was finally published in 2020. It's actually published in March 2020, just when COVID hit. So people were focusing on other things rather than our book. But this book was the basis for the course that I taught in Vienna. It goes into the basic science of this memory reconsolidation model, emotion, memory, their interactions, the role of sleep, etc. And then talks about memory reconsolidation and how it applies to different kinds of psychotherapy, psychodynamic. It's relevant to CBT, certainly emotion-focused psychotherapy, etc. And then chapter on the research agenda, both clinical and basic research. So we said that there are three essential ingredients for enduring change in psychotherapy, and I think it's relevant to the kinds of patients we've been talking about. First, you have to activate old memories and old feelings with or without awareness of their connection to the past. This was Freud's original model of change, in the 1890s. So it wasn't totally wrong. It was just incomplete because it's not enough to activate the painful emotion. I think you have to concurrently engage new emotional experiences that change old memories through reconsolidation by transforming and expanding the emotional content of the memories. And then you have to reinforce the strength of these new memories and their semantic structures by practicing new ways of behaving and experiencing the world in a variety of contexts. So we highlight, emotion is really critical to the change process because, emotion and memory have a very strong connection. Synaptic plasticity, which is the molecular basis for encoding memories, is enhanced by the neurotransmitters and hormones that are activated by emotional arousal. Identifying and tagging what is important to remember is a foundational principle of memory function because the brain cannot possibly retain all the information that comes in during the day, nor would it want to. Okay, so an original component of this 2015 paper was the integrated memory model. And we proposed that there are these three entities or functions that are always interacting. It's impossible to activate one with the other. One is episodic memories or personal experiences. The second is semantic structures or generalized knowledge, and emotional responses, arousal, action, and feeling. So I know time is short, so I'll just say that we think that what we're dealing with in psychotherapy is an internal working model of the social world that is well adapted to the early childhood environment, but is maladaptive in the adult environment. And those schematic memories are a type of semantic memory. And that you have new experiences in psychotherapy that update those semantic structures, and they update them because of the emotional significance of what's transpiring. So the best way, I think, to think about the relation between episodic memory and semantic memory or semantic structures is that semantic structures are a distillation of the key elements of episodic memories. Okay, so, and we use this example of a young child, learning about animals and goes to the park and sees a creature that has wings, feathers, beak, and fly, and it's red and medium-sized. It's a robin, sees a dog and a cat. It doesn't overlap, but then a canary is yellow and small and has these same features of core features, wings, feathers, beak, and can fly. It's a typical bird. We're abstracting from these episodic experiences. How is this related to psychotherapy and somatization? Well, relevant features of recurring situations are extracted, including who is involved, what transpires, how it feels, when we're growing up, how to respond, and how others respond to you. These memories are the elements of the internal working model of how the world of object relations operates, right? Okay. So recurrent maladaptive patterns are an expression of implicit emotional memories. Clients often come to psychotherapy because they're unhappy with aspects of their social or occupational lives. They're typically unaware that this part of the behavioral pattern triggered by interpersonal situations that are reminders of problematic situations from the past. The problematic response to these situations consists of behavioral patterns that aim to ensure avoidance of the experience of intolerable emotion. Okay, so particularly in the case of trauma, personality is kind of organized around avoiding dreaded, intolerable experiences. And I think people come to clinical attention when environmental circumstances are such that those intolerable emotions can't be avoided anymore. So we think that in psychodynamic psychotherapy, interpersonal processes are really foundational, right? Because the problems that bring people into therapy start in the context of early childhood relationships. People seek help because they're having problems in interpersonal context, social and occupational, and the problems get resolved in interaction with the therapist. So working with affect and creating corrective emotional experiences is the key to successful treatment. And I'm a big fan of Hannah Levinson's work, and I teach a course on it, to the residents, and we use the American Psychological Association video recording of the 6-session treatment of Becky, as a way of teaching this. Okay, so it's important I think, to recognize that, psychoanalytic theory has been updated in this century, okay? And, traditionally we thought of psychoanalysis as a way of creating a new narrative. Through insight, you could have a new understanding of yourself, right? But it's more than that. Psychoanalysis is the active construction of a new way of experiencing self with other. And I think it's really important to recognize that classic psychoanalytic theory viewed interpersonal relationships as secondary expressions of intrapsychic processes. But the Boston Change Process Study Group involved these psychoanalysts and child development researchers coming together. And they focused on how research in child development suggests that the experience in interpersonal relationships is primary and that the mind evolves as an adaptation to these experiences. Concepts of conflict, defense, and fantasy are abstractions that are higher level constructs that are superimposed upon the more basic, implicit, automatic level of lived experience. So the implicit process of relational knowing is the operational expression of the internal working model in action. Lived experience is represented at the implicit level. The implicit process of relational knowing involves what is expected regarding what other people will say and do, how you will feel, how you're expected to behave, how events typically unfold. This is your internal working model in action in real time. This view is consistent with implicit emotion. It's continuously active in the background, guiding behavior. And this is what we're trying to change. The lived experience of interaction with other people is where development occurs and where change happens. So psychotherapy is a continuation of a developmental process that kind of got arrested or stunted, right? And corrective experiences make further development possible and decrease the vulnerability to having intolerable experiences and symptoms. Okay. New experiences, new understanding, or both. Okay, if we're seeking enduring change, a goal of therapy is to change the internal working model of social relationships. Insight consists of understanding what the internal working model is, but understanding alone doesn't change the working model. I'd say that's true for insight as well. Talking about emotions without experience and expressing them does not change the emotional elements of the schematic memory. New emotional experiences update the internal working model and thus change how future situations are construed and responded to. So it's not unusual for people in therapy to talk about something they've never told anyone before, and they expect ridicule, shame, and rejection. But then the therapist responds with compassion, empathy, and acceptance. That updates the schema, if you will, and the person is more likely to predict that there's a possibility that other people may be more accepting and they may be more willing to be open with others. Here's a lecture in itself. The implicit emotional messages inherent in an interpretation may matter more than the words used to promote insight. And I'll say it again. There's all sorts of, implicit emotional messages inherent in an interpretation, such as, I care about you. I want to help you. Your behavior is understandable. I don't reject you. We can do this together. That's, I think, more important than the actual words that are used. It's not the words that you used and the correctness of the interpretation is irrelevant because that does foster the connection. But what really matters, I think, is the emotional messages. Now, I think that's sufficient for change. I think insight is not sufficient for change, but insight likely extends the gains achieved from new experiences. So if you have a new experience of being accepted, and then you can understand it, it makes the whole experience and its relation to the past cognitively accessible and usable in thinking through problems in the social context in the future. Okay. Psychoanalysts did not like the idea of corrective experience. It was put forward by Alexander and French in 1946, but they thought it was, it was contrived, manufactured, but importantly, a de-emphasis on interpretation of an insight, which was viewed as unacceptable, an unneeded emphasis on emotional experiences, because what could be more emotional than to re-experience the old conflicts in the context of the transference. But I think that there's just a focus on emotion in terms of the origin of the pathology and the current symptoms, and not emotions as a mechanism of change. And of course, corrective experience did not adequately take into account the transference relationship with the therapist. So we've recently arrived at the idea of a corrective emotional relationship as the core process, because it retains a primary focus on the transference relationship with the therapist as the focal point of therapeutic interaction and psychoanalysis. It bypasses the conceptual baggage of corrective emotional experiences, focuses on schematic memories corresponding to the recurrent maladaptive pattern rather than episodic memories of specific events. It captures and highlights abundant, relevant, implicit, as well as explicit emotional processes in the therapeutic interaction, provides repeated emotional responses and experience inconsistent with expectation, while old memories and old feelings are activated, entirely consistent with how memory reconsolidation works. And I would say that, Stefan During, chair of psychoanalysis at the Medical University of Vienna, agrees with this, okay, which was very refreshing. And here is a picture of Stefan During, me and Hannah Levinson, when we gave a joint presentation on the corrective emotional relationship at the Sigmund Freud Museum in Vienna last June. And I noticed that our relative heights actually corresponded to the duration of the treatments involved, where Stefan is advocating longer-term intensive psychoanalysis, Hannah time-limited dynamic psychotherapy, 16 to 20 sessions, and proposing advocate for traditional psychodynamic psychotherapy. All involve a recurrent maladaptive pattern, updating implicit learning with contradictory information, transforming intolerable into tolerable distress, applying transformative experiences in therapy to the external world. We said more intensive, longer duration treatment is needed when you have early trauma, lack of trust, lack of epistemic trust, and impaired capacity for self-regulation, right? That would be an indication for longer-term intensive treatment. But I think that when it comes to patients who are somatically focused, such as the one that I presented at the very beginning, I don't think that's the answer. I think rather we can take advantage of the three-process model of emotional awareness and add the bodily component to psychotherapy, because patients with persistent bodily distress manifest an abundance of negative affect, both that which they can report and that which they can't. They have reduced emotional awareness, and they have a lack of trust in interpersonal relationships. So traditional therapy doesn't work so well. Obviously, you have to do more. And we can coordinate, I think, mind-based and body-based interventions based on the three-process model. Promoting emotional awareness involves a combination of three processes: affect generation, affective response representation, and conscious access. Body-based interventions activate and modulate bodily emotional responses and promote conscious awareness of the body. And obviously this is overlapping with what it had presented regarding embodied mentalization. Mind-based interventions activate verbal representations of emotion and conscious awareness of emotional experiences. Coordinating interventions across the two domains may have synergistic effects in transforming maladaptive emotional responses. So here are here are body-based interventions that are mapped across the top, across the three processes of affect generation, affect representation, and conscious access. And we can divide them into bodily interventions that involve increased attention to bodily experience, such as breathing exercises, biofeedback, interoceptive training, and somatic experiencing. Self-initiated physical activities like exercise, dance, power posing, relaxation training, walking, tai chi, and yoga. You can see that they're activating emotions in process one, right? Clinician-initiated bodily interventions, category C here, chiropractic manipulation, massage, physical therapy, somato-emotional release, therapeutic touch. They're activating emotion. They may be modulating to a certain degree. But when it comes to process two, there may be nonverbal affect representation, but only somatic experiencing has that verbal component. And with regard to process three, conscious access, it's mostly somatic awareness that's being promoted, not emotional awareness, okay? Now, what about mind-based interventions? Art therapy, ACT, CBT, emotional awareness and expression therapy, emotion-focused therapy, focusing, mentalization-based therapy, psychodynamic psychotherapy, psychodrama. Some are activating the emotion at process one, but they almost all are promoting verbal representations of affect in process two, and conscious attention to emotion, right? So the idea here is that the body-based interventions can really facilitate process one. The psychotherapy can facilitate process two, and both body-based and mind-based can facilitate process three. And I'm proposing that we do this in a kind of coordinated manner, whether it's done by, different practitioners or the same practitioner. There's all sorts of ways of doing this, which we can discuss. And I'm putting the finishing touches on this paper with Shoshana Kroner and Mark Lumley. Mark Lumley was a well-known pain researcher in Detroit who's developed emotional awareness and expression therapy for pain, for fibromyalgia, which outperformed CBT. Shoshana Kroner, now a postdoc, who actually was an undergraduate at Bar-Ilan University. She's American, now back in New York. Conclusions. Insight requires recognizing the emotional origins of persistent bodily distress. To be clinically useful, insight also requires experiencing the distress in relation to the context that generated it and adapting to the new reality. That's not what I'm arguing for, because their barriers to doing so are intolerable, unmentalized distress, impaired emotional awareness, and distrust. A corrective emotional relationship may achieve therapeutic goals without insight, although insight may be useful. Bodily interventions engage patients at the somatic level and promote emotional awareness combined with conceptualization and attention. So that concludes my presentation. I thank you for your attention. I'm sorry if I went over time, but I really appreciate the opportunity to speak with you. Thank you.
Thank you so much, Richard, for this immensely rich and stimulating and complex talk. And I'll start maybe with in order to help myself and maybe others to digest
Yes.
and kind of process and try to integrate a lot of the things that came. So I want to share this thought and trying to bring together some stuff. So we talked today about several different but connected kind of tensions or dichotomies. The kind of insight which is more a mind-body cognitive insight, maybe what Yaakov referred to more, versus a more emotional insight or awareness. The tension between deficit versus defense, insight versus corrective emotional experience, intrapsychic versus the interpersonal, the top-down, the mind-based interventions versus the bottom-up, the body-based interventions. And this kind of also echoes and brings to mind the old famous debate in the 80s between Lazarus and Zajong. What comes first in affective experience? Is it emotion, the more the meaning, the cognitive aspect of emotion? And maybe a common thread that's beautifully integrated in the way you present it is trying to bridge the tensions in those dichotomies, which is not so an either or how we kind of hold together both the insight and the corrective emotional experience. Maybe therapy needs both. So I'm just
right. I think
thinking out loud. I hope it's helpful. Okay.
Right. I think that's true, but I'm prioritizing emotional experience because I think that what makes it so difficult to promote insight and to create change is that we're dealing with intolerable affect. And I think that we can only really change the intolerable to tolerable through an empathic, trusting relationship, which doesn't happen overnight, obviously. But I think physical touch can actually be beneficial in that.
Thank you, Professor Lai, for your integrative talk. It was really, it taught me a lot of things, and all my clinics where I work, we have psychologists, we have physiotherapists, doctor, movement therapist, and I think that if you have the same language and the same
Yes.
view of thinking,
Yeah.
and you know to send the patient to the therapist, it will be synergistic. And if you send him just to physiotherapy here, to psychology here, and they don't speak together, they don't think together, it can be completely to the other side. If even counterproductive, it can be. This is why it's very important to have multidisciplinary clinics that work together with the same view of thinking. We can see so nicely.
Well, thank you. I think that emotion and emotional awareness and the way that I framed it does provide an integrative framework that hopefully everyone can relate to.
Thank you. Somebody has a question, want to say something?
Fascinating talk. I had many associations over the talk, but one thing in Israel now we have a lot of PTSD and trauma. We're expecting to have more and more because of the war.
Yes,
and there's a very popular book in Israel translated by Van der Kolk, and some kind of like mystification of the body as a prophet, and at some point of the talk I thought, well, maybe he's going there, but then I understood, and I would like to hear what you think about it, that you don't think that it's only the body can speak and we can just actually understand the body by the signals that we can't have, but we need to have this the transformation to emotion, and then or to open all the channels simultaneously, but not to go directly to the body as some kind of like oracle from Delphi, or like the body knows what we don't know, and
right.
And that was interesting to me because at some point I thought, well, maybe we can work with a trauma patient through the body without being without the obligation to the words. But
Right.
I believe it's wrong, right? I mean, we can't just go to the body. We have to open all the channels simultaneously.
Yes, yeah. I mean, going back to that case that I presented, I mean, this is a woman who had a, constricted social life, and, she had this very close relationship with her mother. Her mother was her whole world, and how does she come to terms with the new reality and deal with the immense pain of the loss, and then go beyond that, right? There's no substitute for bringing it to the higher level of the actual context. But I think the fundamental change is to, this patient, we asked her about how is it that, you don't have any sadness? And she said, well, I've been through so much in my life, I've just adopted the strategy of, focusing on the future and not dwelling on the past. And that, it served a certain function, but obviously the unmentalized distress is kind of wreaking havoc on the body. Yeah. So ultimately it has to be worked through, and it's not easy to do, which is, I think, what we're talking about. But thank you so much for your presentation, because that was a wonderful introduction. There was obviously a lot of overlap in our talks.
Can I ask a question?
Yes.
Yeah. So I'm wondering about the mind-body dichotomy and how it's engraved within the different, by having different professions.
Mm-hmm.
And how sending someone to a psychiatrist or a physical therapist, I mean, I understand how we're structured at the moment, but bringing into consideration all we know about the neurobiology and how to reach to a patient, what's your thoughts on maybe thinking differently about how to create a new language of that different therapists can speak in?
Yeah, well, I think we do need specialists in all these different areas. I mean, we need physicians who are focused on the organ system, et cetera, in question. But I think that, I think the key is for there to be communication, between all the members of the multidisciplinary team, to really try to understand what the person is dealing with. I know that what comes to mind is, in Germany, they have separate departments of psychosomatics and psychotherapy. And these separate departments, they have their own inpatient units and day hospitals and clinics. And in the, they used to have these 3-month hospitalizations for patients who had, they were unable to work because they had, intractable pain or other somatic complaints. And basically what the different clinicians were providing all these different modalities. There's individual, there's group, there's art therapy, there's, dance therapy, yoga, art therapy. And so the clinicians would make observations about what was happening with the patient, and they would communicate. So it's like, the art therapist might see, a change in colors in the drawings, more red is coming out, and somebody in the group therapy would say, oh, I noticed that there was some anger being expressed for another person. That's something different. And so basically the team was kind of doing the mentalization and really trying to promote the conversion from implicit to explicit processing in a way that the patient could handle. So that's my answer to that. Does that make sense?
Yeah, well, I was thinking about how the educational system in which physicians or physical therapists or psychiatrists, if they would all have more an ability to have emotional awareness for themselves when they treat patients.
Yes, yeah. So I was at the what has been called the American Psychosomatic Society. The name is changing in January, but I was at that meeting let's see, when was it? Last week. And and we had a symposium on the question, you know, how can we want everyday medical practice to incorporate the biopsychosocial model. How can we get physicians to incorporate that, right, and go beyond the biomedical? And so, you know, there were examples of where that's done very well at the University of Rochester, for example, where George Engel was, where they have, you know, a lot of collaborative care, and they have embedded psychiatrists on the medical units and things of that sort. And so there's a lot of dialogue there. But I think that I gave a talk about how neuroscience is it's the foundation. You know, the brain is where mind and body, you know, come together. And not only that, how is it that social support influences medical outcome? You know, it certainly does. How does it get under the skin? Well, it never left the skin in the first place, because it really has a lot to do with your perception of social signals. So I think that an appreciation of the integrative role of the brain in mediating between the external, both the body and the social world, external world, are external to the brain. The brain is creating models to make sense out of both, and navigating and integrating. So I wrote an editorial that you have to explain the biopsychosocial model in biomedical terms. And I think neuroscience enables you to do that.
Thank you.
Yeah.
We're a bit over time, but this is a lovely discussion. And so if anybody needs to get out, it's understandable. But if we do have time for more questions, it's
Yes.
also welcome. You're okay with time, Richard?
Absolutely. Definitely.
Okay.
I'm sorry I went over time, but...
No, you were okay. It was we took the delay from the beginning of the day.
Completely okay.
Good.
More than okay.
I'm happy to continue the discussion. Sure.
So any other comments or thoughts from the audience are welcome.
Perhaps anyone who wrote in the chat and maybe things in the chat that we didn't look at.
Oh, yes. Please do.
I may say share another thought I was keeping from the morning from Yaakov's presentation. When he was presenting the second case, where this woman under hypnosis had a very good relief, and then right afterwards, the pain comes hitting back. And this is very suggestive to me of unconscious guilt going on, and like a self-punishing. I'm practicing more of experiential dynamic or intensive short-term psychodynamic, and I'm more and more fascinated and seeing it more and more, the issue of guilt as a very strong source for a lot of symptoms, and especially the intractable patients where you try everything. There's like Freud talked about it, the need to suffer. And I'm finding that, like Yaakov suggested this $1 million question with the fairy that he is very useful with many patients. I'm finding myself more and more using the guilt question. And sometimes it kind of, when you say to a patient, even in the first interview in the beginning, you say something like a patient like Yaakov described, this may be a crazy question, but feel free if it doesn't fit you. But, is there any part of you, like using a dissociative language, but is there any part of you, I'm seeing that, first mirroring, you were feeling good, and then some part of you kind of attacks in, as if you're not allowed to feel good. Is there any part of you that might feel that you need to suffer, that you're not allowed to feel good? And for many patients, they just say, you know, it's crazy, but yes, I'm supposed to suffer, you know, and this brings a very fruitful kind of discussion and kind of brings the unconscious guilt, making it more out in the open. So,
maybe when we work with hypnosis, we don't speak about it. We feel it. The patient feels it, and he's there. And when he is there, thing happens, and it happens much stronger and faster than when just you speak about it. I call this a paradoxical response, and I see paradoxical response with patients when it is more conversion disorder than functional normal, what I call low threshold or functional somatic disorders. And we see about the compass. In the compass there is C, which is a conflict, and there is S, which is self-punishment. And when the patient is into the trance, there is dissociation, and there is possibility to speak to those parts, to the part that wants to be free, good, and the other one that doesn't. And you can do reconciliation of those two parts when you are in hypnosis, and it works with ego state therapy, in hypnosis, or other techniques.
You say it works. I mean, so it has lasting effects, and patients overcome their somatic focus.
Many times it is like you are doing, when you are doing the hypnosis, you open things, and then it works much faster in the normal treatment.
Yes.
I work with psychologists. For example, I work with Golan Shahar, and he asked me to do hypnosis with one of his patients, and we reveal things much faster, and then he works on them, so it can enhance the treatment or booster it.
Great, if it works, amazing.
Works. And for headache, I'm a neurologist. You see, I treat many headache patients. Hypnosis for headache is amazing. Is amazing. Self-hypnosis is easy, it's fast, is very rewarding.
Okay, so there's work done under hypnosis, and then they come out of the trance, and then they learn about what was happening during the hypnosis. How does that work?
There are two kinds of hypnosis. There is, I would call it technical hypnosis, just self-regulation to teach the patient self-regulation, like meditation plus some suggestion, and 3-4 appointments, and he can treat his headache, because headaches are, or what I call second cluster, which is migraine, or third cluster, which is tension type headache, and just self-regulation is enough. But when you need something that is more, which is deeper, which is not conscious, and the patient can speak with the psychologist for a year, and just around, and don't get into the deeper problem. When you are into the trance, you can speak, and he feels it. He doesn't rationalize it, and he won't turn around, and then you can touch it, and then continue with the psychologist, and work together.
I see. Well, I do see a correspondence in terms of working with emotions, because I think that you're directly influencing the schemas in the same way that you may be with hypnosis.
Hypnosis touches the anterior cingulate cortex. The anterior cingulate cortex is the main area that is working in hypnosis.
I didn't know that. That's that's great.
And there is enhancement with the prefrontal cortex, and
Well,
you can see how it works. It's amazing.
That's
I
great.
see that.
Well, well, I would just say that, I mean, what we're talking about now is we're heading toward an integrated neurobiological model of psychosomatic conditions. Yeah.
I see we have two more questions in the chat. Judy, do you want to speak up your question, or should I read it?
I could say it. Yeah, thank you. So one thing is that it's the kind of emotional reworking that you're talking about. It sounds very similar to kind of the notions put forth by Edgar Levinson. Would you say?
I'm not sure who Edgar Levinson is. I'm sorry.
Oh, from the interpersonal tradition.
Okay.
Okay. Sorry, I'm just wondering if you.
Well, I'm not familiar with his work, but certainly this is a very interpersonal process. But I think the key thing is, well, the authenticity of the therapist to have real emotional experiences and to have a trusting relationship so that there's a capacity, a sufficient comfort to be vulnerable, to activate all of the intolerable emotions and then to have them transformed, you know, through the interaction. If that's what he said, then I totally agree.
Yeah, he was like he is like a follower of Sullivan. Okay, that's one thing. And then the other thing is that, can you clarify a little bit more about how to know, let's say for a particular patient, what type of intervention might be indicated for them?
Among which modalities are you talking about?
No, in other words, let's say, are you suggesting that based on, you know, let's say based on somebody's level of awareness, you know, somatic intervention might be appropriate for somebody else more, you know, X or the other type of treatment would be indicated? Like, I'm just wondering if you have any sort of map of that, how that works.
It's not well worked out, but I can say that when you have a lot of negative affect that's both, you know, expressed often in terms of the body and anger at the medical system, but also a lot of unmentalized distress associated with all the things that are happening in their lives that they don't have insight about. And, you know, they're not able to form a good therapeutic alliance, right? And they have reduced emotional awareness. I think that just operating at the verbal psychological level is not going to engage them sufficiently. So I think that you want to bring in bodily interventions as well, and ideally either from the same therapist or with two therapists closely communicating with one another, you know, because I think that bodily interventions can modulate the intensity of the stress. It can add, you know, a more positive valence to experience. You know, healing touch can promote a sense of trust that is more immediate than can happen in, you know, in a conversation when your default assumption is that people aren't trustworthy. So I think what I've proposed is a general framework, and it remains to be worked out, but I think these are the general principles that I think make sense. And all of you are in a position to try out some of these ideas. I'd love to hear what happens.
Okay, so thank you so much, both for Richard and the other presenters and all the audience. It's been a wonderful and stimulating and heartwarming, and I think it sure brings a lot of both feelings and ideas. So
very good.
Thank you very much.
Yeah, if it's possible to copy what's in the chat and send it to me, I'd appreciate it. I haven't had a chance to see what's in there.
Okay. Thank you. And Shabbat Shalom, everybody.
Yes.
Thank you.